Welcome to the Approach to ECG Quickfire session. Tonight's session delivers a concise, high-impact overview of ECG interpretation, tailored for busy healthcare professionals like you. We'll refresh essential ECG principles, sharpen diagnostic accuracy, and boost confidence in recognizing both common and critical cardiac patterns. Whether you're revisiting the basics or strengthening your clinical edge, this session promises to keep your interpretation skills sharp and your decision-making faster. Thank you for joining us. Let's get started with the Approach to ECG Quickfire session.
Yay! Good evening, colleagues. Welcome to the Clinical Care Platform. It's a Thursday. That means we are nearing the weekend. Yippee. Look who's showed up there, Brother Ryan.
Brother, your audio, brother.
Thanks, brother. We are trying by God's grace. Someone has gate crashed into my room. She knows how to open the door.
Hello.
Hello, Ceci. Come, take Zuri. Come. Yeah. Hey, colleagues. Yeah, the owners of the house are here. Okay, just leave her. It's fine. Yeah. I have a beautiful gate crasher, so it's okay. Yeah, I just wanted to say good evening and welcome to the Clinical Care Platform. We are so grateful to have you on board because it gives us an opportunity to impart knowledge, to add value to your lives, and that helps us as well to lead a fulfilling life. So thank you so much for joining us. For those of you who are joining us for the first time, as a platform, we have a mission which is to improve patient care. And we really want to invite you to join us on this journey so that we help you to be confident, to always be kept updated. The ultimate thing is competency. And on that note, in internal medicine, we have at least 2 programs that can help us to get that far. The first one is that on the 29th of this month, it will be a Saturday. We are going to have a masterclass on laboratory test interpretation. Please don't miss it because it's one of those awesome masterclasses we have. And secondly, I want to say that the diploma preparatory programs are still open for registration, including for internal medicine, because webinars we teach, but in those programs, at least there are some assessments, and we are able to then know that how many people we have helped to be competent, but also to contribute towards your career trajectory. Colleagues, today I'm not alone. As you can see, I'm with Dr. Ryan Suepesad. He's our in-house physician, our coach, our mentor. And today is going to be very interesting. We are going to go through fire. That's all I can say. And there'll be a lot of graphs going up and down. Brother Ryan, can I hand over to you to take us through today's session? Thank you.
Brother Mawela,
Hola.
hello. Hola. I think your daughter wants to learn ECGs, eh?
Hey, she's
Yeah,
like, she's like,
we should not deny her.
No, you know what? She has grown up. Now she knows how to open the door. At least she used to knock. Then I'll be the one who opens. Now, she just does it like that. Yeah. Thank you, colleagues, and a warm welcome to you.
Thank you, everybody. Very good evening. God bless you. Thanks for joining us. I'm just getting my toolbar sorted out here. That's better. Oh, oops. Yes, good evening, Brother Mawela and everybody. Thanks for joining us. Yebo, can you see my slides, hear my voice?
100%.
100%. Thank you, brother. Thanks for joining us, guys. It's a beautiful Thursday evening. And it's almost the end of the week, and we thank the Lord for the opportunity to be here and to learn about everybody's favorite topic in the world, ECG. Okay, my name is Ryan. Great to be here. First of all, it's good to have an attitude of gratitude. Thank you, Lord, for this beautiful day. And it's always good for us to give thanks. That's God's will for us. And also to thank this dashing young man, Brother Mawela, and his wonderful team at the CCP. Thank you once more. If we don't say it enough, thank you. Thank you. Tiabonga, bye, donkey. Muchas gracias. Thanks for the sacrifice and dedication and commitment, and we really appreciate the effort you put in to help us to sharpen our skills, to help us to become better doctors, to render better service to our patients. God bless you in abundance. Okay, guys, this is our 33rd session in Think Like a Physician. We started the series last year, I think January or February, and I mean, we've reached 33 installments so far, and all thanks to God and for the CCP and Brother Mawela. So the learning objectives from each session is to list the common and dangerous diagnoses that could potentially cause each symptom. But obviously, it's a bit different today because today, instead of focusing on a symptom, we are focusing on an investigative modality called electrocardiogram. So a slightly different twist today. Usually we say we develop a diagnostic plan for your individual patient, and then we said examples would be we go through relevant terms and definitions, and then we go through the diagnostic framework. You guys are familiar with this, right? Like when we went through chest pain, we did it anatomically. Then when we went through edema, we said pathophysiology, and we went through abdominal pain, different anatomical approaches, etc. But today, I mean, it's a slightly different take on things because we're not doing a topic in medicine. We're doing an investigation, right? So, this is number 33. This is a synopsis of what we've covered thus far. It's quite a bit of information spanning the length and breadth of different disciplines in medicine. So I thought we can do something different and talk about ECGs today. Because ECG is something we use commonly every day. We got patients coming in with some cardiovascular complaint, chest pain, dyspnea, paroxysmal nocturnal dyspnea, edema, palpitations, a syncope, a heart failure. And, all of these, we got to do ECGs, alrighty? And of course, whenever you see the laughing man, it's time to laugh. And now it's time to laugh. So according to your ECG, you are not a good-hearted person. Well, I don't think that the ECG can tell you about the character of people. It can only tell you about the heart, okay, in the physical sense, not the figurative sense. Okay, this is an important disclaimer. Today's lecture is not, and I repeat, is not a comprehensive review of the physics behind ECGs and many technical aspects of interpretation. For a full comprehensive breakdown of ECGs, feel free to enroll in our next ECG masterclass, where we spend a whole 8 hours on a Saturday talking about ECGs and ECGs and ECGs and more ECGs. Today, we're going to do quick fire and look through some common just review the basics of ECG interpretation and take you through some common traces that we may see daily in the clinics and in the ward. Okay, just to kick things off, I've got a clinical case for you. It's not a very long stem. This is just a small question. You got yourself a 68-year-old man who, let's just say he has cardiovascular risk factors of hypertension, diabetes, dyslipidemia, cigarette smoking, family history. I forgot to put that in, but let's assume he has all the cardiovascular risk factors, okay? And he comes in with a 1 hour history of central chest pain, and his ECG is shown, boom, look at that ECG. Feast your eyes on that ECG trace, okay? And just register in your mind, take a photographic of that ECG, and then the question goes on and says, well, what are you looking at? Is it A, pericarditis? Is it B, acute inferior MI with posterior extension? Is it C, acute anterior MI with lateral extension? Is it C, D, an acute anterior MI, or is it E, an acute inferior? Let's go back, let's go back, let's go back, let's go back. Okay, so different ST elevation. Where is the ST elevation? Well, V1, V2, V3, V4, maybe a bit in V5, all righty. Okay, so and we'll go to the different territories, guys. So what do you think about this? Let's see. Why don't you guys type in the chat box for me? What do you think it is? A, B, C, D, or E? And I will give you maybe 20 seconds to type into the chat box, tell me what you think, okay? And while we're waiting for 20 seconds, maybe I can favor you with a song item. Okay, but I actually don't want to break any computer speakers, so I'd rather not favor you with a song item. I'd rather just look at the answers coming in. And the answers are coming in fast, thick and fast. And we've got, oh man, okay, we've got a mix. It looks like it's between C and D today. A lot of people saying C. We've got a D in the house. We've got some. I think it's mainly between C and D. So C, let's have a drum roll. Brrr. C is correct. Acute anterior MI with lateral extension. And do not worry, we're going to talk about why this is the answer. All right. So as with most things, to understand something, you need to go to the root of it. And so at the heart of ECGs is understanding electrophysiology of the heart. Now, going back to first year physiology, everybody, you know that we have an electrical conduction system in the heart, okay? And we have the action potentials. Action potentials actually are responsible for causing contraction of muscle, okay? And so action potentials travel down a certain electrical conduction pathway, and all of us know this. Okay, so back here at the junction between the superior cava and the beloved right atrium is something called the sinoatrial node. Now, SA doesn't stand for South Africa. It stands for sinoatrial node. And the impulse starts there. It percolates through the atrial muscle and comes to something called the atrioventricular node, the AV node. And the AV node then comes down the bundle of His. And the bundle of His then splits up into bundle branches. We've got the beloved left bundle branch and the right bundle branch. The bundle branches, which then divide into the Purkinje fibers, and hence from the Purkinje fibers, the ventricular myocardium, and hence we have cardiac muscle contraction, right? So essentially, if you're looking at the way the impulse moves, it moves from the right atrium, it goes through the atrium, and it also moves over into the left atrium, down the AV node, right? Then down his bundle, the bundle branches, percolates down the Purkinje fibers, and thence to the ventricular myocardium, okay? And then, okay, how do you set up the ECG? Okay, this is a very primitive representation. And of course, ECGs are not done on coffee tables, as shown here. It's normally done on a cart, the little cardiac trolley if you're in the wards, or maybe you have a specific ECG room in casualty where you do your ECGs. Whatever the case is, okay, you have your precordial leads. We call it the precordial leads. V1, V2, V3, V4, V5, V6. So V1 and V2 are in the fourth interspace. So V1 is in the right fourth interspace, parasternal. V2 is in the fourth left interspace, parasternal. And usually V4 is at the position of the apex of the heart, okay? And V3 is somewhere between V2 and V4. V5 is usually in the fifth interspace in the anterior axillary line, and V6 in the mid axillary line, fifth or sixth interspace, there and thereabout. Then you have the limb leads, the right arm, the left arm, the right leg, the left leg. Yeah, okay. So that's basically the ECG setup. I'm sure everybody's familiar with how to set up an ECG. Okay. And this is a very rudimentary trace, right? But essentially, just to introduce you to the orientation, I'm sure you guys are already aware of the orientations. The standard or bipolar limb leads. Now, by bipolar, I don't mean a mix of mania and major depression. But that's a different kind of bipolar, right? No, I'm talking about standard or bipolar in the way of electrical conductance, action potential, electrical potential. And that's 1, 2, and 3, right? Those are your standard limb leads or bipolar limb leads. Then, of course, we have AVR, AVL, AVF. The A stands for augmented, A for augmented, and that stands for augmented or unipolar limb leads. That's the AVR, the AVL, and the AVF. And then everybody's favorite precordial leads, that's V1 through V6. And you can anatomically, right? So V1, looking at the right side of the heart, right? V1, V2. So actually, we call these the septal leads. V3, V4, we call these the anterior leads. V5, V6, the lateral leads, okay? But all of them collectively, V1 through V6, are called the precordial leads, all right? And then we have our beloved rhythm strip, because here you can see a whole 10-second run of specific leads. So this is V1, this is V2, and V5. Now, this is not by convention, right? Conventionally, the lead which we use for the rhythm strip is lead 2. Okay, but sometimes you can set the machine such that it gives you 3 different rhythm strips from 3 different leads, but that's certainly not the convention. Okay, so here's our beautiful trace. So I'm zooming into just one heartbeat. Okay, I'm just going to remind you guys of certain portions of the ECG and what they stand for. So we have the PR interval, right, from the start of the P to the start of the R wave. Okay, and what the PR interval essentially represents is atrial depolarization. Okay, and the segment here called the PR segment, right? Now, I know the nomenclature interval versus segment, etc. I'm not going to get too much into the nitty gritty because that's not the aim of today's lecture. The aim of this lecture is a very practical based lecture. If you want to get into the semantics and etc., then I encourage you to have a look at our ECG masterclass, right? So PR segment basically signifies atrioventricular nodal delay, AV nodal delay. QRS is what represents a ventricular depolarization. Fantastic. And then we have the ST segment here. Okay. And everybody is always interested in the ST segment. Is there ST segment elevation? Is there ST segment depression? I wonder, because that tells me about ischemia, doesn't it? Okay. And then, of course, ventricular depolarization is a T wave. Then the very cute interval, I call it the QT, like cute, very cute. QT interval. Everybody makes a big deal about this because QT prolongation is a complication of certain drugs, especially drugs in overdose, tricyclic antidepressants. I'm talking to you. Yeah, we make a big deal about QT and also certain MDR TB drugs. I'm sure you guys know bedaquiline and friends. Okay, yeah. So that's essentially what we're talking about, right? PR interval is what we look at in the context of heart block, AV block, right? The P wave is basically atrial depolarization. The AV nodal delay is the PR segment. The QRS is ventricular depolarization. The ST segment is what we talk about in the context of ischemia and infarction and ventricular depolarization by the T wave. Now remember, potassium, hey? Potassium and the T wave have a very long-standing relationship because hyperkalemia causes tall, tinted T waves. Hypokalemia can cause U waves and inverted T waves and a whole lot of stuff we'll talk about later on. Okay, I know. The writing's very small. Okay, but I had to kind of give you a summarized version of the way we look at ECGs before we get into the meat of the talk. So here's your basic approach. So you want to check, is this the right ECG for my patient? I don't want to be looking at the ECG for Mr. Inkabinde when actually it's Mr. Smith's trace that I'm looking at, right? You make sure your patient corresponds to the right ECG trace, the age, the gender, the name, and then the calibration by convention is 25 millimeters per second of paper speed, and the voltage is 10 millimeters per millivolt. Now, if it's not set to this convention, you may misinterpret things that are normal for being pathological because the complex looks either too narrow or too wide, etc. So it's good to always quickly check the calibration before you interpret the trace. Okay, now let's talk about rate. How do you calculate rate on the ECG? Well, if your patient is in sinus rhythm. Now, what do we mean by sinus rhythm? Sinus rhythm means that for every P wave, it is followed by a QRS, and every QRS is preceded by a P. All righty? And usually the P wave is positive in days 1 and 2. Now, for rate, if your patient's in sinus rhythm, the rate is calculated by taking 300 divided by the number of big squares between the RR interval. Let me show you. Let me qualify that, right? Let's first of all have a look at this. Now, if you do the maths, one small box is equal to roughly 40 milliseconds, which is 0.04 seconds. And therefore, one big box, which is 5 millimeters, which is 5 small boxes, is therefore 200 milliseconds, which is 0.2 seconds. Why am I telling you this? I mean, who really cares, right? Well, if you want to determine the rate, all you do, by some simple mathematical calculation, you come to this. Your heart rate is equal to 300 divided by the big boxes between RR waves, or between beats, okay? That's the magic interval you guys have to remember. This is the formula I want you guys to remember. Heart rate is equal to 300 divided by the big boxes between beats. Now, this only applies if your patient's in sinus rhythm. If your patient's in atrial fibrillation, you can't use this. We're talking about sinus rhythm. P before every QRS, QRS preceded by a P. That is sinus rhythm. Now, let's look at some examples. How are you going to determine the rate of this ECG? Using the 300 rule, okay? So we said it's 300 divided by the number of squares between the RR interval. How many squares can you see here, everybody? 1, 2, 3. Therefore, my rate is 300 divided by 3, which is 100. Now, having said that, bradycardia is defined as a heart rate below 60. And tachycardia is a rate above 100. Now, some people will say, yeah, okay, tachycardia above 90. But I prefer to say 100, okay? So yeah, that's how we do it. Let's do another example. Okay, 300 divided by the number of big squares between the RR wave. So how many big squares can you see here? Let's count. 1, 2, 3, 4, 5, 6, 7. All righty. Oh, 8. Okay, fine. 300 divided by 8, 38. Let's think about this heart rate, everybody. You think a heart rate of 38 is okay? No, we call that bradycardia. And then for those of you who are used to seeing this in the wards, what's the next thing? We look at the PR interval, man. Is this atrioventricular block? And then AV block comes in 3 flavors, first, second, third degree. And second degree is divided into type 1 and type 2. But we'll talk about that later on when we're addressing bradycardia. Quick fire, quick fire. Guys, if you have any questions and stuff, feel free to type in the chat box, eh? And even in the Q&A tab, and we will have a look at that at the end. I can see the Q&A tab is, oh, it says hello. Hello, Natasha. Natasha is there in the Q&A box. Okay. Now, this looks a bit funny, but can we use it? Can we use the 300 rule? Let's look. What the number of, well, we see two big blocks, right, between the RR. And therefore, the rate here is, oh, it's tachycardia. It's 150. Is that normal? No, that's not normal. Okay, that is tachycardia. Right? So, do you guys have an understanding of how to calculate rate so far? If your patient's in sinus rhythm, everybody okay? Give me a thumbs up if you guys understand how to calculate rate. Quick fire rate. Yeah, okay, we are together on this one. Excellent. Okay, now for those of you who are mathematically inclined, right? There's an easy way to do this, right? Because we are saying that your rate is 300 divided by the number of squares between the RR interval. So if you, therefore, you can associate this quick fire with this. So some physicians actually memorize this table. And so, boom, they just look at the ECG and tell you, the rate is such and such. And you are like, wow, like, how did you do that? You just memorize this table, right? So if there's one big square between the RR, the rate is 300. If it's 2, it's 150. If it's 3, it's 100. If it's 4, it's 75. If it's 5, it's 60. If it's 6, it's 15. If it's 7, it's 43. So if you want to be a star on the post-intake round and you're looking at the ECG and you suddenly say, boom, this patient's rate is something, without even looking at the ECG. And it's like, wow, but this is do it, right? So if you want to, you can remember this table, or you can work it out in your head, whichever you prefer. I mean, it's totally up to you, right? Okay, now, this is the disclaimer here, guys. You can't apply the 300 rule if your patient is not in sinus rhythm. So if your rhythm is irregular, and what is the commonest arrhythmia in clinical practice? The commonest arrhythmia in clinical practice. It starts with atrial and ends in fibrillation. It's A to the F. A to the F. Atrial fibrillation, okay? The classic example is atrial fibrillation, and we cannot use the 300 rule in the context of atrial flutter, atrial fibrillation, and so forth. So here, obviously, you can see that the interval between the RRs is not constant. That's your first alarm to say, hey, this is not a regular rhythm. Okay. And therefore, we can't use the 300 rule. So here we use something called the 10-second rule. And the 10-second rule basically means that you count the number of QRSs in a 10-second period, and the rhythm strip at the bottom runs for a duration of 10 seconds. And you simply multiply that by 6, because that's 60 seconds, and that's your rate per minute. Okay, makes sense, right? Let's flesh that out with a couple of examples. So what we're saying is that the heart rate, if you're dealing with a rhythm that is not sinus rhythm, is the 10-second strip, the number of QRSs in the 10-second strip multiplied by 6. Easy, right? Let's look at some examples, right? So in this particular case, how many do we have? We've got 17 QRS complexes in 10 seconds. Multiplied by 6 gives me the rate of 102 per minute. Okay? All right. Not so difficult. Let's see here. What do you think about this one? 22 QRS complexes in 10 seconds gives me a rate of 132. Is this normal? Oh, no. This is tachycardia. And for those of you who are very astute ECG technicians, where are my P waves? Hello, P waves. I can't see no P waves here. This is atrial fibrillation. All right. So with atrial fibrillation, we'll talk about it later, but you don't have P waves and you have irregular QRS complexes. Boom. The next part of call is you discuss with your patient about rate and rhythm control. That's one arm. And the other arm of atrial fibrillation is, are we going to anticoagulate my patient? Then we call upon the Chadvask and the Hasbled and the physicians in the house. You know what I'm talking about. Okay. So rhythm, okay, so we touched on that. So that was rate. The rhythm we said, I think we touched on sinus rhythm. There's a P before every QRS, and every QRS is preceded by a P. Okay, for axis now. For axis, you basically want to look at either lead 1 and lead 2, or lead, so it basically lead 1 and any of the inferior leads, okay? And the normal axis is in the leftward direction, okay? So your lead 1 and your inferior lead should be positive, okay? So if your lead 1 is negative, and let's say lead 3 is positive, that puts you into the dimension of right axis deviation. And we'll go through the causes of right axis deviation, right? But if your lead 1 is positive and lead 3 is negative, that puts you into the land of left axis deviation, okay? But don't worry, we're going to see some examples coming up shortly. Intervals, okay, the PR interval we said is from the start of the P to the start of the R wave. And normal is what? 3 to 5 small boxes. That's what I'm talking about. That's a normal PR interval. If your PR interval is prolonged, what do we call that? Atrioventricular block, which comes in 3 different flavors, like we said, first, second, third degree, and second degree type 1, type 2. We'll talk about that. QRS should be maximum 3 small boxes, which is 0.12 seconds. Anything wider than that puts us in the domain of bundle branch block. We talk about left bundle branch block, we talk about right bundle branch block. The QT interval should be roughly around a half of the length of the RR interval. And if it's more than 420 milliseconds in a male, or more than 440 milliseconds, you better watch out, because that's a long QT interval, right? And anything above 500 puts you in danger. A danger of what? Danger of who and what and why? Danger of a dangerous rhythm called torsade. Now, torsade actually is a precursor to ventricular fibrillation. And ventricular fibrillation, if you don't address that, is uniformly fatal. And that is why we make a big deal about QT prolongation, guys. Okay, and then, there's many causes of long QT, right? We talk about antibiotics, some antipsychotics, some antidepressants. Hello, TCA, tricyclic antidepressants. I never liked amitriptyline. Amitriptyline in overdose is renowned for prolonging your QT interval. Antihistamines, antiarrhythmics, hypokalemia, hypomagnesemia, congenital issues is a whole lot. Even raised intracranial pressure can do it, okay? Then we're talking about hypertrophy. You guys may be familiar with the terms P mitrale and P pulmonale. So if you have a very tall P wave, which is more than 2.5 small boxes in width rather, and usually it's a bifid P wave, which has a notch in it, we call that left, rather P mitrale, and that speaks to left atrial enlargement, right? But if you just have a very tall P wave, which is more than 2.5 small boxes tall, we call that P pulmonale, and that's right atrial enlargement. Then we talk about left ventricular hypertrophy, okay, where you basically take the R in V5 and add it to the S in V1, and together, if it's more than 30 millimeters, that speaks to left ventricular hypertrophy. And where do we see that? In a setting of long-standing hypertension and severe aortic stenosis, any impedance to left ventricular outflow. Do not worry, we're going to look at examples of each of these coming up, right? Coming soon to a cinema near you. Okay, and right ventricular hypertrophy, basically you're looking for a tall R in V1, And we'll look at some examples, okay? So I don't want to get too hung up about these definitions. I like to flesh it out with examples. Now, I put this in here because this is really, 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 really important. In the wards in South Africa, every day, if you work in the internal medicine space, you are bound to see ischemia in some way, shape, or form. Now, when you have a patient with ST elevation myocardial infarction, that means that the entire ventricular myocardium has been infarcted. And infarcted tissue is dead tissue. Okay? And the management of STEMI is beyond the scope of today's talk, but essentially, these are the changes that happen in evolution. Okay, so initially, before the infarction, everybody's happy. There's your P, there's your QRS, your T wave, fantastic, fantastic. And then, boom, the chest pain happens. Oh, doc, severe retrosternal crushing chest pain radiating to my arm. I've got nausea. I've got dyspnea. I've got diaphoresis. Oh, please help me. Okay, so at the point of the ST elevation, what happens? ST elevation, right? You may have a hyperacute T wave. This happens within minutes to hours. Right, but if the patient comes in a bit later, okay, some hours to a day later, what happens? Your T wave begins to invert. Hello, T wave inversion. But also, my Q wave is starting to form. All right, okay, fine. ST elevation is still there. Then 1 week later, what happens? Your ST is coming down. It's coming down to almost the isoelectric line. Your T wave inversion is resolving, but your Q wave is deepening. And then months to years thereafter, what happens? The ST segment is down, the T wave is back to normal, but your Q wave remains for life, right? So if you see a patient who has a Q wave on the ECG, that's evidence that they probably had an infarct in the past. Is everybody okay with this? Can you guys give me a thumbs up if you're okay with the evolution of the STEMI? Okay, guys. Now, this is a bit of a tricky summary. I don't want to mention too much here, but I think this is more for the registrars and the physicians. Yeah, but this is an important thing I probably want to touch on. Your territory of your infarcts. Okay, so the inferior territory on the ECG is 2, 3, and AVF, and that's taken by the right coronary. I mean, if you want to get into the territories of the different vessels, okay, so right coronary, the marginal is taking the inferior, which is 2, 3 AVF. And the septal territory V1 and V2 is taken by the proximal LAD, the left anterior descending. V3, V4 taken by the distal LAD, and these are the so-called anterior leads. 1 AVL, V5, V6. 1 AVL, V5, V6, so-called lateral territory taken by the circumflex, and then posterior. I don't want to talk too much about that. Okay, and then of course we have so-called STEMI equivalents, but this is more for the registrars to know, the Wellens T waves, the De Winter, and then in times past, we said if you have a new left bundle branch block, that you can't interpret ischemia in the context of a left bundle, but now you can. And the cardiologist that came up with this criteria is called Scabosa. Scabosa is a Mexican cardiologist who said, hey, you know what? Maybe we can predict ST elevation in the context of a new left bundle branch block. But this is not for everybody. This is probably for people who are more involved in cardiology. So I don't want to mention this in any great detail tonight. Okay, look at this, cardiac arrest. And I would have gotten away with it if it weren't for that middling defibrillator. Because now the heart is being arrested for the cardiac arrest. Okay, guys, I know a little bit, just a few more boring things, and then we'll dig into the ECGs. We spent half an hour already. Okay, this is just a summary of what we said, right? So the P is atrial depolarization. We said it's 2.5 small squares, and we spoke about P pulmonale, P mitrale. PR interval, we said, is basically 3 to 5 small blocks. Anything longer is AV block. QRS is ventricular depolarization. Anything longer than 3 small blocks is heart block. And if you look at left and right ventricular hypertrophy, we said the S in V1 plus the R in V5. Okay, we look at some examples, okay? ST is important for ischemia, infarction. T wave is for ventricular depolarization. And we spoke about potassium changes impacting this part of the ECG. QT interval, we said the important thing is that a long QTC is associated with torsade. Torsade becomes VFib. VFib is uniformly fatal unless you intervene. And we said that this is also associated with lots of drugs, lots of electrolyte problems, the digoxin, TCAs, etc. The U wave we only care about U waves in the context of hypokalemia, maybe ischemia. Alrighty. Okay, this is an example of right axis deviation. So we said we're looking at lead 1 and lead 3 or lead 1 and AVF. So 1 is not exactly positive. See, there's part of the QRS that's above and below. In fact, I would say that the predominant deflection here is negative, right? So if you think about the axis that we looked at, if 1 is negative, so if lead 1 which normally points this way, is negative, and lead 3 AVF is positive, this puts us into right axis territory. And this is an example of right axis deviation. Okay, once again, looking at 1 and lead 3. Okay, so here we see that lead 3 is predominantly negative. And if you plot this onto our chart here, if 1 is positive and lead 3 or AVF is negative, that puts us into left axis territory. And that's what we call left axis deviation. Okay. So essentially, let's have a look at this systematically. Okay. Is it sinus rhythm? Yes, it is sinus rhythm. Why? Because I have a P before every QRS, and every QRS is preceded by a P, and the interval between the RR is constant. Right. So some people talk about the card method, where you take your card, you place it here, and you mark the crest of the R waves, and then you move the card to and fro, and it should be, the interval should be regular if it's sinus rhythm. Okay. Then what's the axis? Well, 1 is positive, 3 is positive. It must be a normal axis. Okay. Then we said, is there any particular hypertrophy? Well, I'm looking at my S wave in V1 plus my R wave in V6. If it's above 30 millimeters, that's left ventricular hypertrophy. Let's count 5, 10, 15, 20, 25, 30. It's borderline left ventricular hypertrophy, borderline. Okay. My PR interval, it's supposed to be maximum 5 small blocks. It is 5 small blocks. Thank you. So there's no AV block. Okay. Any ST changes you can see? There's no ST elevations. There's no ST depressions. There's no T wave inversion. This, my friend, is an absolutely normal ECG. What is the rate? Well, we said it's regular, so we can use the 300 technique, isn't it? 300 divided by the number of large squares between the RR. So 1, 2, 3. So about 300 divided by 3 is about 100. Okay. Fantastic, normal ECG. This is right ventricular hypertrophy. So looking at V1, remember that V1 looks at the right side of the heart. And which direction is the mean axis of depolarization? Towards the left. So normally V1 should give you a negative deflection because the action potential is going away from the right side. But here we've got a big positive deflection in V1 telling us, hello, there's something wrong with the right side of the heart. This is what we call right ventricular hypertrophy. And if you also notice, there's some T-wave inversions of ST depression in lead V2 and V3. So that's what we call right ventricular hypertrophy with a strain pattern, RVH with a strain pattern. This is an example of left bundle branch block, and as you guys can see, that my QRS is wide. It's supposed to be smaller than 3 small blocks. My QRS is wide. And they talk about William and Marrow. Thumbs up if you guys heard about the acronym William and Marrow, where William stands for left bundle branch block and Marrow stands for right bundle branch block. Okay, I think that's a nice way to look at it, right? So here my QRS is wide, so I know it's bundle branch block, and it looks like a so-called W in V1 and a so-called M in V6. So William starts with W, ends in M, and the L stands for left bundle branch block. Fantastic. All right, these are classic examples of infarction. So where's the ST elevation, guys? Well, I think it's probably in V2, V3, V4, V5. Okay. So this is an anterior wall infarction, right? So I would say anterior septal because V2 is actually a septal lead and V3, V4 anterior. So anterior septal myocardial infarction. Fantastic. What do we see in lead 3? ST depression. Okay. And this is what we call reciprocal change. So if you have an anterior infarct, usually you have reciprocal, which is so-called mirror change in the inferior territory. What is happening here? Oh man, ST elevation again. Where's my ST elevation? In the inferior territory this time. 2, 3, AVF. 2, 3, AVF. Where's my ST depression? Aha, V2. Right? So this is reciprocal change, anterior reciprocal change for inferior infarct. Okay? Couple of examples. This is atrial fibrillation. How do I know it's atrial fibrillation? Well, for one thing, my complexes don't look very regular, do they? No, they don't look regular. For another thing, I can't see any waves. Atrial fibrillation, boom, there you go. Okay, now I got a couple of fire examples. We're going to be moving quick. But before that, wife was in the ICU. The doctor said, it seems she's in a coma. Husband said, please save her. She's just 28. Suddenly, the ECG started beeping and her hand moved and her lips mumbled. He spoke, darling, I'm 27, not 28. Never get the age of a woman wrong. Just a side note. Okay, guys. So yeah, this is a normal ECG. So I just put this up because it's good to be systematic. With anything in life, you have to have an approach and you have to be systematic or else you are going to miss things. Whether it is an arterial black gas, whether it is a chest x-ray, whether it's an ECG, whether it's lab interpretation, whether it's CT scan, ultrasound, you've got to have a systematic approach. So, and our approach to ECG is rate, rhythm, axis, intervals, hypertrophy, ischemia. And we've been through all 6 of these before. So this is the normal ECG. I don't want to talk too much about it, but it's the normal ECG. All righty. So what we're going to do now, I'm going to give you guys maybe 15 seconds or so. Just tell me what's the pathology here. Just type it out for me on the chat group. Just go crazy. Go crazy. What is the pathology here? Just type it out. Based on what we discussed. Anybody? Who's typing for me today? Alrighty. Okay, we got Dr. Matao saying NSTEMI. I love it. 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 Atrial fibrillation is where we're at. Because we're saying here, guys, my QRSs are not regular. You can see the intervals are very irregular. And there's no P waves. Boom, atrial fibrillation. I love it. Fan, absolutely tastic. Okay, there we go. P wave absent. Yeah, don't worry about fibrillary waves. The main 2 things is the P wave is absent and the rhythm is irregularly irregular. Okay. Now, the main causes of atrial fibrillation in clinical practice, condition that causes a large left atrium, creates a nidus for atrial fibrillation. A big left atrium is not what God intended. And usually the left atrium is because of either pressure or volume load coming into the left atrium. And most often it's due to mitral stenosis. Very tight mitral valve. You can't get the blood from the left atrium to the left ventricle. And henceforth, there's hypertrophy of the left atrium, right? But also there's something called the holiday heart syndrome, which is a paroxysmal atrial fibrillation. Now, I don't want to get into atrial fibrillation too much, but there's different types, right? There's paroxysmal, there's permanent, there's lone atrial fibrillation. But alcohol can induce a paroxysmal atrial fibrillation, which we call the holiday heart syndrome. Hyperthyroidism, thyrotoxicosis can do it. Coronary artery disease can do it. Long-standing hypertension can do it. We call the acronym MATCH. Right? So whenever you see atrial fibrillation, it's not enough just to say, I want to control the rate and the rhythm, and I want to anticoagulate. A good physician will look for, is there an underlying cause for my patient's atrial fibrillation? And that's when you do an echo, you look at the dimensions of the left atrium, look at the mitral valve, look at the gradient across the mitral valve, look at the size of the mitral valve, look at your pulmonary pressures, and then you ascertain, is there something wrong? Is there alcohol in the history? What's my TFT? Okay. And then, of course, if you see areas of hypokinesis or akinesis or whatever, then you know that the patient probably had an infarct on the echo. Take a history for hypertension, guys. All righty, all righty, all righty. We're moving, we're moving, we're moving. Okay, this is just to show you guys once again the territories. So 2-3 AVF we said was inferior. Then in blue we said V1 and V2 is septal. V3, V4 in green is anterior. And we said in red, 1 AVR, V5, V6 is lateral. AVR is all on its own. Nobody really cares about AVR. Shame. AVR has no grouping. Okay. This is a diagrammatic representation of ECG changes as days and years go on. So hyperacute, you may have T waves, you may have ST elevation. Within minutes to hours, ST elevation, ST depression. Hello, ST depression. Yes, and then ST elevation may persist for hours to days. ST depressions can persist all the way down to weeks and years. Then pathological Q waves start developing within 1 hours to days later on, and they persist for life. Okay, fantastic, fantastic. Okay, for those of you who love cardiology, and I know there are a couple of cardiologists in the house, this is taken from our ECG masterclass where we went into detail regarding territories and such things. This is a nice summary diagram for you, right? But the topic of today is not acute coronary syndrome. Okay, so that's just there. All righty, guys. I think how much time do we have? Okay, probably about 20 minutes or so. Tell me, just give me 2 or 3 words. Tell me what's the pathology here. What is the pathology on this ECG, everybody? Just go crazy, go crazy. Type it out. Let's see. Aha. Yes, Dr. Bezana. I think Dr. Bezana is in our diploma program, if I'm not mistaken. MI, definitely. Isak says STEMI, inferior MI, inferior MI, inferior STEMI, inferior STEMI. I like it, I like it, I like it a lot. I like it a lot. Okay, inferior STEMI, that's what I'm talking about. And then if you have to determine the timeline of this, you can say it's acute. Why? Because there's no Q waves. If there's Q waves, it must be old. This is new because I can't see no Q waves. And what's happening in AVL? Aha, ST depression. Thank you so much. This is reciprocal change for inferior MI. Fantastic. I love it. Well done, guys. Okay, here, what do you think is happening in this trace? Go crazy, go crazy, go crazy, guys. Go crazy. What's happening on this trace? Anybody? Let's take some submissions on this one. Oh, okay, we got one posterior MI there, Ibo. Inferior anterior. Yes, now we're talking. Now you're talking my language. Yes, anterior septal MI. Beautiful. Because we said V1, V2 is septal, V3, V4 is anterior. All righty. But if you have to do the timeline for this, would you say it is acute or what? Because I'm seeing my Q waves. Look at this crazy Q wave here and this crazy Q wave here. There's no way that this is an acute infarct. So are you going to thrombolize this patient? No, I'm not. Why, doc? Why are you not thrombolizing while there's Q waves? Okay. Yeah, so there we go. Anterior septal STEMI, which is probably not acute. Okay. Okay, I don't want to talk too much about management of STEMI, but we'll leave that for another day, right? For those of you guys going for interviews, a pet topic to test candidates, whether it's the MO post in internal medicine, whether it's a registrar post, they love to ask about complications of myocardial infarct because we know that most people know how to diagnose a MI, right? You do your history, you do your enzymes, you do your ECG, you put them together, you say what kind of MI it is, but not many people know complications of myocardial infarct. And that's where they can catch you out. So I've just put this in here for you. You can screenshot it if you want. So there's early complications and there are late complications, all right? I'm not going to get into that too much. Why did the window go to the doctor? It had a lot of pain. Yeah, a lot of pain. Okay, guys, I'm just going to zoom through these ECGs, all right? Because in the interest of time, I think I should just whack them. So what can you see here? Obviously, there's ST elevations, but there's also some T wave inversion in the lateral territory, right? So if there's V5 and V6, I'm looking at 1 in AVL because they all fit in the lateral territory. Yes, the T wave inversion in AVL, not so much in 1, but I also have Q wave, don't I? I have Q waves in the septal territory, in the anterior territory, with lateral ischemia as well. This is most likely an anterolateral MI, which is not new, right? So I would say old anterolateral MI. Okay, here, what's happening here, guys? What is happening here? Q waves in the inferior territory, 2, 3 AVF, 2, 3 AVF. This is the old inferior MI. Okay. Okay, now for those of you who are talking about Scarbosa's criteria, I'm not going to get into that tonight. But if you're so inclined, you can have a look. This is in your ability to interpret ischemia in the context of a new left bundle branch block. So the proverbial teaching is that we treat all new left bundles as if it's an acute STEMI, but Scarbosa went into that and said, well, actually, not really. We can interpret the ST elevation, but this not for tonight, okay? So this is what is this, a left bundle branch block? Because the QRS is longer than 3 small blocks, and it looks like William, isn't it? There's my W in V1 and my M in V6, and this is a left bundle branch block. Left bundle branch block. What are the causes, guys? 4 main causes in clinical practice of a left bundle. Usually it's cardiomyopathy. Usually it's ischemic cardiomyopathy. Somebody who had a myocardial event before and is coming now with heart failure and probably dilated cardiomyopathy on the echo. Okay, a severe CA.